Good afternoon. I'm Dr. Lavanya, Ranjith Kumar, Oral Pathologist. Today going to see a topic of odontogenic cyst. These are my contents today. So we are going to see about introduction of a cyst. What are the classifications of the cyst to the up to the date, the 2017 classification, and we are going to discuss about eruption cyst, dentigerous cyst, calcifying odontogenic cyst, gingival cyst of infants, gingival cyst of adult, and lateral periodontal cyst. So coming to the definition of the cyst, it is like it is given by Ramer in 1974. He defined it as a pathological cavity having a fluid, semi-fluid, or gaseous content, and which is not created by accumulation of pus. And by Marx, he has defined it as a pathological cavity lined by epithelium. So, and Kelly and Kay in 1966, they defined it as an abnormal cavity in hard and soft tissues which contains fluid, semi-fluid, or gas, and it is often encapsulated and lined by epithelium. And main thing is its abnormal cavity which is benign in nature. So, elements of the cyst. What are the elements of the cyst means? Like the cyst, it has three main components, which is the central lumen or cavity, which contains fluid or any of the glycosamine proteins, any of the enzymes, everything, which can play important role in the pathogenesis of each and every cyst. And it is covered by the second layer. The cystic lumen is covered with a cystic lining epithelium. It can be stratified or it is not. It is can be simple, and can be keratinized or non-keratinized. And around this epithelial lining, we have a fibrous capsule, which is termed as connective tissue wall or connective tissue stroma, which composed of collagen fibers. So this is a histopathological image which is representing the elements of the cyst, where it has this empty space. It is called cystic lumen or cystic space. I'll say it as, and it is sometimes it is filled with keratin flakes or enzymes or any of the fluids, proteins, etc. And after that, we are going to see a epithelial lining. See, this is epithelial lining, which can be a multiple layer or simple epithelial lining, or it can be stratified. Sometimes it can be keratinized or non-keratinized. And after that, it is covered with a capsule, which is called connective tissue capsule. So coming to the pathogenesis, we have three main phases for development of this cyst. In each and every cyst, we have three main components, which is cyst initiation, the factors which plays important role in cyst initiation, and cyst formation, and also the cyst enlargement or expansion of cystic cavity. And for the in detail, for each and every cyst, we are going to see in detail the pathogenesis, how the cyst initiation takes place, formation, and the enlargement takes place. So coming to the classification of the cyst, it is classified mainly into cyst of jaw, cyst associated with the maxillary antrum, and cyst of soft tissues of the mouth, face, neck, and salivary glands. So coming to the cyst of jaws, it is given by Shear. He told it as a cyst of jaw is developed. It is classified as broadly classified as epithelial and non-epithelial. Okay, then this epithelial is further classified into inflammatory, developmental. This developmental is further classified into odontogenic and non-odontogenic. So coming back to this inflammatory, epithelial means the cystic cavity or cystic lumen, which is lined with the cystic lining, which is called true cyst or epithelial lined cyst. And the non-epithelial lined cyst means they will call it a pseudocyst or false cyst. Example will be the aneurysmal bone cyst, static bone cyst, or traumatic bone cyst. These are all pseudo epithelial cyst. And in case of epithelial lined cyst, it is further classified into inflammatory and developmental is further classified into odontogenic and non-odontogenic. Odontogenic means that is a cyst which is related to the it is thought to arise from the remnants or components of the components that is related to the tooth. And in case of non-odontogenic, it is not the cyst which is developed is not related to the odontogenic. It can be developmental. It is developed as any of its remnants. Like for example, in case of epidermoid cyst, the inclusion of the epidermal layer, where it is in the thyroglossal cyst, where there is a remnant of that the thyroglossal duct lining. So these are the examples. Like for example, we have a lot of fissural. I mean, we call this as a non-odontogenic cyst as a fissural cyst. So fissural cyst includes median palatal cyst, nasopalatine cyst, globulomaxillary cyst, nasoalveolar cyst, thyroglossal cyst, dermoid cyst, epidermoid cyst. These are non-odontogenic cysts. And the odontogenic cyst, what we are going to discuss today. And in case of inflammatory process, the cyst which is related to inflammation or the pathogenesis of the cyst is the inflammatory background. So it will be radicular cyst or apical cyst, residual cyst, paradental cyst, inflammatory cyst, collateral cyst, inflammatory collateral cyst. And the developmental means it can be, or it's a developmental is odontogenic. So odontogenic means odontogenic keratocyst, eruption cyst, dentigerous cyst, calcifying epithelial odontogenic cyst, glandular odontogenic cyst, gingival cyst of infants, gingival cyst of adults, lateral periodontal cyst, botryoid odontogenic cyst. So non-odontogenic, I told you it is like a nasopalatine duct cyst, mid-palatine raphe cyst or nasolabial cyst. To consist of soft tissues of mouth, face, and neck and salivary glands. So it includes dermoid or epidermoid, branchial, and the thyroglossal duct cyst, anterior median lingual cyst, oral cyst with gastric or interstitial epithelium, cystic hygroma, nasopharyngeal cyst, thymic cyst, cyst of salivary glands, parasitic cyst, which is called hydatid cyst or trichinosis, cystic cysticercosis cellulose. These are the cysts which is involving the soft tissues of the mouth, face, neck, and salivary glands. The sixth cyst of maxillary antrum, which is mucocele, and retention cyst, pseudocyst, and postoperative maxillary cyst. So in 19, coming back to periapical cyst and residual cyst and bifurcation cyst. So WHO classification in 2017, they classified this odontogenic cyst as dentigerous cyst, odontogenic cyst, lateral odontogenic keratocyst, and lateral periodontal cyst are botryoid odontogenic cyst, and gingival cyst, glandular odontogenic cyst, calcifying odontogenic cyst, orthokeratinized odontogenic cyst, nasopalatine duct cyst. So in this, dentigerous cyst is updated. So there is no any changes, and odontogenic keratocyst, before it was considered to be the keratogenesis KCOT, keratocystic odontogenic tumor, and now this is classified under the it is cyst. It's a odontogenic keratocyst because they mainly considered this as a tumor because of the patch gene involvement. But this patch gene is also involved in non-neoplastic conditions, so they told this has to be called as cyst, but it is a most common and aggressive cyst. And lateral periodontal and botryoid odontogenic, there is no change in that. Gingival cyst also there is no change. GOC, which is glandular odontogenic cyst, which is they have given a diagnostic criteria which is can be and that could minor and major diagnostic criteria which can be continued, and there is no change in that. And the calcifying odontogenic cyst, it is classified back to as a cyst. Before it is considered to be the calcifying odontogenic tumor. Which is related to dentigerous ghost cell tumor, and now it is classified back to as cyst. And orthokeratinized odontogenic cyst. Whether we in odontogenic keratocyst we have a parakeratinized epithelium, but if it is having a odontogenic keratocyst, if it is having a orthokeratinized epithelium, then it is called orthokeratinized odontogenic cyst, which is classified as a separate entity. and nasopalatine duct cyst, which is also one called to be as only non-odontogenic cyst. It is not related to of the odontogenic cyst. So these are the changes, and the cyst which is given by WHO in 2017 under the odontogenic cyst category. So the cell of origin for the cyst main is odontogenic rest, which is called the source is rest of malice, which is originate from the epithelial root sheet. So it is related to inflammatory cyst, which is periapical cyst, and reduced enamel epithelium, which is from the enamel organ or dental lamina, which is of dentigerous cyst, enamel organ, which is of dentigerous cyst, and the rest of dental lamina, which is called the cell rest of serous. So the epithelial connection between the mucosa and enamel organ. So all other odontogenic cyst, OKC, lateral periodontal cyst, and gingival cyst of adult and newborn, and GOC, this will come under the cells which are related to that is like rest of dental lamina or remnants of dental lamina or the cell rest of serous. So frequency of the cyst in oral region is that radicular is very common because of the dental caries as a common bacterial infection which is involving the oral cavity. So radicular, because of that, the granulation, periapical infection, the cyst can be developed from the granulomatous condition. So the radicular cyst is very common, followed by dentigerous cyst, where the impacted tooth, mostly mandibular molars and maxillary molars, third molars, are involved. So it is considered with the second cyst, and OKZ the third one. So coming back to the odontogenic cyst, first is eruption cyst. What is eruption cyst? We thought everyone is saying it is a soft tissue counterpart to the dentigerous cyst, involving the erupting tooth, whereas the dentigerous cyst develops around the crown of an unerupted tooth lying in the bone. Eruption cyst occurs when a tooth is impeded in its eruption within the soft tissue, and the epithelial lining, the dilated cystic space, is reduced enamel epithelium. So here they are saying as like so it is the eruption cyst is a soft tissue counterpart of dentigerous. That means of an involving tooth eruption, which is involving the tooth eruption. So they are saying that dentigerous cyst is the cyst where there is a, if it is called as dentigerous cyst if the cyst or the tooth is impacted within the bone. But this is the clinical image which is showing a dentigerous cyst. Here the eruption, and there is a cyst development which is within the bone. This is the bone area, this is soft tissue. So this is dentigerous cyst. But in case of eruption cyst, so the tooth is erected through the bone, but it is not erected out from the soft tissue. So this is called eruption cyst. See here, this tooth crown has come out from the bone, but it is not from the it is not it is not coming out from the soft tissue. So it is considered to be eruption cyst. So that's why it is called a soft tissue counterpart of dentigerous cyst. Frequency. The most commonly affected is deciduous and permanent teeth. Most frequently, the anterior to first permanent molar is affected. It is about 0.8% of jaw cyst or of eruption cyst. And Anglio et al. In 1998, he told maxillary permanent dentition is most commonly affected. But 2004, Bodner et al. He told mandibular central primary incisors and first permanent molars are also affected. And the size of the cyst will be, it's about 1 to 1.5 centimeter. Number will be one or more than one. Duration will be the brief history of about 3 to 4 weeks. Radiographically, it will show as a soft tissue shadow, no bone involvement. Sometimes dilated or open tooth can be seen. So, but the differential, there is confusion whether it can be eruption cyst or eruption hematoma. So to find out that, when a cystic cavity contains a blood, swelling appears which is purple and deep blue, then it can be eruption hematoma, which is not to be a cyst. So coming back to the cystic, and the transformation can be used to differentiate between the eruption hematoma and eruption cyst. And coming to the pathogenesis of eruption cyst, the tooth in this case of eruption cyst is embedded in the soft tissue, right? It is not erupted out from the soft tissue, but erupted out from the bone. And factors responsible to impede eruption is that not known, but they are saying, some other authors are saying it is mainly due to the dense fibrous tissue that is responsible for that impediment within the soft tissue. And the cystic lining epithelium is thought to derive from the reduced enamel epithelium, that is dental lamina. So another pathological reason they are saying is that one is it is mainly due to the dense fibrous connective tissue component which is present above the crown of the tooth, which prevent it from the eruption. The second is the administration of cyclosporine, which may lead to development of eruption cyst. O'Hara et al. In 2002, he told that development of multiple eruption cysts in dogs given with oral cyclosporin. And Kukzek et al. 2003, he told that eruption cysts developed in a boy treated with the cyclosporin for a heart transplantation. After cyclosporin is switched to tracolimus, no further eruption cysts developed. So he told that this can also be one of the causative factor or the etiological factor for the development of the eruption cyst. So coming back to the histopathology, first the cystic lining is, I told you that cyst has a three component, which is cystic lumen, cystic lumen or cavity, and lining epithelium, and the connective tissue capsule or capsule. So the cystic lumen empty, it may sometimes contains fluids. It sometimes will not contain fluid, but if it is contains a blood filled spaces, then it is called hematoma. And the lining capacity, lining epithelium of this cyst is comprised of keratinized stratified squamous epithelium of gingiva. And the connective tissue component is acellular, this dense collagenous component. Sometimes it shows a eosinophilic hue. And the follicular connective tissue, when it is a gingival tissue, it is acellular. And if it is a follicular connective tissue component, it is densely cellular and less collagenous and basophilic, which may contains odontogenic epithelial islands. So, and the cystic lining. So this is a, see, this is the soft tissue component and this is the cystic lining epithelium. So the first is the soft tissue component. It can be gingiva. Most commonly it is a gingiva. So it is lined by parakeratinized stratified squamous epithelium. And this connective tissue of this gingiva is acellular and densely collagenous, very tightly packed. We can see tightly packed collagen fibers with eosinophilic hue. Eosinophilic means pink color, which is of eosinophilic hue. And coming to the follicular connective tissue, see, cystic lining is there. So under this only we have the tooth. So tooth and the cystic lining is maybe it can be reduced of it is of odontogenic epithelial lining of or reduced enamel epithelial lining. And it is the connective tissue component contains a densely cellular. Here it is acellular, but it is densely cellular. But here it is less collagenous, it is more collagenous, but it is showing a basophilic bluish tinge, which contains some few odontogenic epithelial islands in here and there in the connective tissue stroma. So this is the difference, and this is the histological feature. And this, I told you, this is of reduced enamel epithelial origin. So it may be 2 to 3 layer thick, and acute inflammatory cells also present if it is inflamed. And epithelial lining is intensely inflamed, proliferates in response to inflammation. So it shows some arcading patterns or spongiosis will be seen. So treatment is not required. Usually it ruptures spontaneously, permitting a tooth to erupt. If this does not occur, simple excision on the roof of the cyst usually permits the eruption of the tooth. Sometimes if it is large, then the marsupiation is required. So it's if it is asymptomatic and if it erupts within a spontaneously, ruptures spontaneously, there is no treatment is required, which will allow the tooth for eruption. But if does not does not occur, if the rupture occurs, if the rupture does not occur spontaneously, then the simple excision of the roof of the cyst generally permits eruption of the tooth and marsupiation. So coming back to the dentigerous cyst, this is a very important common odontogenic cyst when compared to the others. So it is also known as follicular cyst, and it is also called a tooth-bearing cyst. So it is introduced by Paget in 1863. He coined this as a tooth bearing cyst or follicular cyst, and most common developmental odontogenic cyst. 20% of all the epithelial lined cyst or jaw. It comprises of 20% of all epithelium lined cyst of jaws. And second most common odontogenic cyst. First is radicular cyst. So, what is the definition given by Neville? Is the cyst that originates by the separation of follicle from around the crown of an unerupted tooth. So, come again, it is a cyst which originates by the separation of the follicle from around the crown of an unerupted tooth. But it is according to the Neville. It by according to the shear, the dentigerous is one that encloses the crown of unerupted tooth by expansion of its follicle, and it attaches to the neck. So the shear, he defined this as a cyst that encloses the crown of the unerupted tooth by expansion of follicle, and it associated attached to its neck. So dentigerous cyst means encloses the crown of the unerupted tooth, and it's attached to the tooth at the cemento-enamel junction. So dentigerous cyst is this clinical picture is showing that it encloses the crown of the unerupted tooth, and it is also attached to the tooth at the cemento-enamel junction. See, it is attached to the neck of the tooth. So it is attached to the cemento-enamel junction. This is the clinical histopathological image, which is showing a similar. This is a tooth with a decalcified section. With it is of a tooth, and it is showing a cystic lining and the lumen, and also the cavity and lumen and the lining and the capsule. So here you are able to see that it encloses the crown of the unerupted tooth. So clinical features is frequently increased most commonly in the second decades, like the 20 to 30 years of age, and peak in the third decade, after which it's decline, and more common in the male. And John et al. In 2006, he told male are more commonly affected, and when compared to female. And according to the race, white people are affected more commonly. Brown et al. In 1982, he told that white people has higher frequency of impaction. Impaction results in dentigerous. So mandibular third molar is more commonly affected, followed by maxillary canine, mandibular premolars, maxillary third molars, according to John et al. 2006, and rarely involves the unerupted deciduous tooth, and occasionally associated with the supernumerary teeth and odontoma. That is, 27.6% of odontomas associated with the dentigerous cyst. Clinical presentation, it is of asymptomatic, and a small dentigerous cyst are asymptomatic. If it is impacted or if it is infected, it will induce symptoms. So the teeth will be missing, or it is impacted, and the pain, if it is impacted, secondary infection is found, then the patient complains of pain. Slowly enlarging swelling will be found. Large cyst may be associated with the pain, less expansion of the bone in the involved area. Extensive lesion may also result in facial asymmetry. So coming back to the clinical presentation again, see, if it is a small dentigerous cyst is asymptomatic, and it shows a missing teeth, pain if the secondarily infected, and slowly enlarging swelling will be found. Large cyst may be associated with the pain, less expansion of the bone in the involved area. Extensive lesion may result in facial asymmetry. So radiographic feature is that unilocular radiolucency area associated with the crown of the unerupted teeth. See, this is a impacted third molar in the mandible. You are able to find a unilocular radiolucent area associated with the crown of the tooth, and it is attached. It starts from the neck, just from the cemento enamel junction, and it is coming from the extending to the other side of the cemento enamel junction. It's totally enclosing the crown of the tooth, and this radiolucency usually is well defined. See, it's well defined, and with the sclerotic border, and but if it is infected, it may show ill-defined borders, and large dentigerous cyst may give the impression of multilocular process because of the persistence of bony trabeculae within the radiolucency. The Again, this is a radiograph which is showing the because of the radiolucency of involved tooth, impacted tooth, the involved tooth, the displacement of the adjacent tooth is also takes place, and also root resorption will be found. A root resorption is found, and cortical perforation also there. See here, this radiograph is showing a cortical perforation, and see here the tooth is displaced, and also there is a resorption of the root. So these are the radiographic features of dentigerous cyst. So coming back to the types of dentigerous based on the radiographic, it is central, lateral, and circumferential. Central means it's the most common type, and cyst surrounds the crown of the tooth, and crown projects into the cyst. Lateral means the cyst grows laterally along the root surface and partially surrounds the crown. So, and the circumferential means the surrounds the crown and extends for some distance along the root, so that the significant portion of the root appears to lie within the cyst. So central means it's the cyst which surrounds the crown of the tooth, and crown projects into the cyst. Lateral means the cyst grows laterally. See this side, it is the cyst is growing laterally along the root surface and partially around the crown. And circumferentially means it surrounds the crown and the extends for some distance along the root, so that a significant portion of the root appears to lie within the cyst. Dental follicle versus dentigerous cyst. So with the radiograph, whether we have to identify whether it's a dilated dental follicle or it's a dentigerous cyst. So radiolucency should be at least 3 mm to 4 mm in a diameter in case of dentigerous cyst. Apoptosis related to the factors and proliferation markers differ between dental follicle and dentigerous cyst. These are the two difference to identify, to differentiate whether it is a dental follicle. So if it is a normal follicle or dilated follicle, it should be less than 2 to 3 mm. It will be 2 to 3 mm. If it is more than, at least if it is more than 3 to 4 mm or 5 mm, then it will be called it as dentigerous cyst. The space is called as dentigerous cyst, and some of the apoptotic factors and proliferating markers can also helps in differentiating from this as a dentigerous, whether it is a dentigerous cyst or dilated dental follicle. So coming back to the pathogenesis again, it's only 1 in 150 unerupted impacted tooth develop dentigerous cyst. So there will be unidentified innate factor which plays important role in development of the cyst. And the expansion of dentigerous cyst is related to epithelial proliferation and release of bone resorbing factors, and an increase in the cystic fluid osmolality. So the cyst can be two types, intrafollicular and extrafollicular. So intrafollicular means which is of accumulation of fluid between reduced enamel epithelium and enamel within the enamel organ itself. If it is extrafollicular, there is no evidence for this theory, but most of them are envelopmental or follicular KCOT. That is, KCOT means OKC, which is keratocystic odontogenic tumor. So mainly it is of intrafollicular and follicular. Extrafollicular, intra means within the bone, it is does not erupt because of the accumulation of fluid between the reduced enamel epithelium and enamel. The enamel or within the enamel organ itself, it results in development of a dentigerous cyst. Or if it is extrafollicular, there is no evidence for this theory, but they are saying that it's of most of them are say it's developmental or envelopmental or follicular OKC. And some are saying that it is also based on the tooth development, like early stage. It can occur at the early stage. If it is occurs at the early stage of tooth development, then the degeneration of stellate reticulum and associated with the enamel, and it is associated with the enamel hypoplasia. If it is occurs after the completion of crown, then accumulation of fluid between the reduced enamel epithelium and enamel, or enamel hypoplasia is not significant. So coming back to the again that if it is related to based on its relation with the tooth development, in case of early stages of tooth development, there will be a degeneration of stellate reticulum. So it is associated with the enamel hypoplasia, because enamel hypoplasia, because the stellate reticulum is very important for the enamel formation. And if it is after the completion of crown, the cystis development is after the completion of the crown, then it is related to accumulation of fluid between the reduced enamel epithelium and the enamel. So the enamel hypoplasia is not significant. So coming back to other follicular keratocyst, which is very rare, very rare type, and it's a tooth is surrounded by its follicle erupts into keratocystic cavity in the same way as erupt into the oral cavity. See, imagine this is a bone, a mandibular bone, and this is a third molar, which is in the ramus area or in the ramal area, which is erupting through the bone, and it is surrounded by some follicle, and that once it is erupts and it's open in the ramus, we have a enlarged or multilocular radiolucency, which is of called as we call as keratocyst. So when the tooth erupts, the erupting tooth, the crown of the erupting tooth will open into the crown of the erupting tooth. When it's erupting tooth, the tooth will open into the keratocyst. So, pathogenesis of inflammatory dentigerous or inflamed dentigerous means, according to the Ban and Altini, three feasible mechanisms exist for histogenesis of dentigerous with inflammation. So, first one is the crown of impermanent tooth may erupt into radicular cyst at the apex of deciduous tooth. So the erupting tooth may intended rather than that penetrate the wall of radicular cyst. It's very rare that radicular cyst of deciduous tooth is very rare. So this is very rare mechanism to happen. So coming back again, that it's a crown of permanent tooth may erupt. See, already the deciduous tooth is having a caries, and apex of this the deciduous tooth is fully infected and results in radicular formation. It is very rare in the condition to develop like radicular cyst from deciduous tooth is very rare, and if it is there, then the erupting permanent tooth will may enter and then penetrate the wall of radicular cyst. That is one. That time it will have a inflammation, fully inflamed connective tissue. And second one is if it is having a periapical inflection of adjacent tooth, then the tooth is erupting through that adjacent because of the adjacent root. Because of that adjacent tooth infection, it also results in inflammation. Third is periapical inflammation of non-vital deciduous tooth, which will result in inflammatory exudate. Then the follicle of permanent tooth will develop. These are the changes and which results in inflammatory condition in the dentigerous. And some are saying that patch protein also play important role, and so loss of heterogeneity in the epithelial lining of dentigerous cyst, which results in this is the initiating event or step for the development. Then the patch gene will be involvement will be there. Then the cystic lining cloned from the single progenitor cell, which results in patch gene expression in the dentigerous cyst, despite alteration or deletion, so that at least other allele being transcribed. So, erupting tooth on impacted follicle obstructs the venous flow, so which results in rapid transduction of serum, pooling of fluid, increase in hydrostatic pressure, the separation of follicle from the crown, and which results in altered capillary permeability and passage of greater quantity of protein that results in cyst formation. So, come again. When the tooth erupting tooth of impacted follicle, so impacted follicle, if the tooth is impacted, it has a follicle that there will be obstruction in the venous flow, which results in rapid transduction of serum and pooling of fluid will be there. Because of that increased fluid activity, there will be increased hydrostatic pressure, which results in separation of the follicle from the crown. So because of that, there is a increased hydrostatic pressure. There will be a accumulation of fluid between the reduced enamel epithelium and the follicle and the crown. Then there will be altered capillary permeability, which results in passage of greater quantity of protein. This results in cyst formation. So the pathogenesis behind how the cyst expansion takes place. Dentigerous cyst fluid contains total proteins level, albumin and globulin ratio, and the immunoglobulins, which is similar to that of serum. So, Brown et al. In 1975 suggested cystic fluid arises as a exudate from the vessel in capsule. So, desquamated epithelial cells, inflammatory cells, and increased osmolality, these are responsible for the expansion of the cyst. And another mechanism is that bone destruction or bone resorption theory, which is related to that. So they, according to that theory, they say that monocyte macrophage infiltrate and stromal fibroblast and epithelial lining, they will release interleukin 1. and that induces a osteolytic cell reaction because of by stimulating osteoclast that results in resorption of the bone, so that expansion of the bone will be, the cystic cavity will be there. So another way is that connective tissue cells will be activated that release the collagenase and prostaglandin, which will result in bone resorption. So this is the mechanism which is responsible for expansion of the cyst by the bone, based on bone resorption theory. So mechanism of bone destruction also related to parathyroid hormone related protein, and modulated growth and bone resorption in odontogenic cyst have high intensity seen in the KCOT. So this is more commonly seen in the OKC or KCOT. And pathogenesis also, some of this glycosamine glycans which are present in the cystic fluid, that is hyaluronic acid and also chondroitin sulfate, heparin sulfate, these all increase the osmolality and hydrostatic pressure, which is responsible for expansion of cystic cavity. So coming to the gross examination, sometimes cyst may be intact. So mostly wall is torn during the surgical procedure, because as the epithelial lining is very thin, it will be torn during the surgical procedure, and inflamed cyst wall will be very thickened, and confirm the cyst which attaches to the cemento-enamel junction of the tooth. Aspiration will be straw colored thin fluid, and presence of A node in the cyst wall, which will be white to yellow node on the luminal surface of the cyst wall. So if it is not infected, the cystic lining is very thin and it will be torn during the surgical procedure. And if it is inflamed, it will be thickened, and it will be attaches to the cemento enamel junction. That is a very important feature which we can identify by with the grossly we can identify the diagnosis, we can give the diagnosis. And the aspiration from the cystic fluid will show a straw colored fluid which is very thin, and albumin and globulin ratio will be very similar to the serum. And presence of AOT in the cyst wall, if the cyst wall contains adenomatoid odontogenic tumor, then white to yellow nodules on the luminal surface of the cyst wall will take place. So coming to the histopathology, the epithelial lining is from reduced enamel epithelium, which will be 2 to 3 or 2 to 4 layers, and the cells are of cuboidal or flat in appearance with a round shaped nuclei, and the cystic lining is most commonly keratinized. And what the changes will take place in this epithelial lining? Sometimes because of metaplasia, mucus producing metaplasia cells will be there, and some ciliated cells also be very rare, and sebaceous cells will be there. So mucus producing cells, because of metaplastic changes, mucus producing cells will be present, which can also give responsible for the development of central mucoepidermoid carcinoma from the, as this is one of the complication because of the metaplastic changes in the epithelial lining. It also undergo as a metaplastic changes to oral squamous cell carcinoma, which is results in development of that. Because of that, it will results in it's one of the complication. And next is in case of intense inflammatory infiltrate, discontinuity in the lining epithelium. I told you, if it is a inflammatory discontinuity in the epithelium, it's localized proliferation in the lining. And if it is inflamed, it is very common. If the cyst is inflamed, then the cystic lining will have retiridges. Otherwise, it is not there. Retiridge is absent in the absent in the cystic lining. If it is infected or inflamed, secondary infected and inflamed, then you will get a retiridges. So because of the infection, there will be discontinuity in the lining epithelium, and localized proliferation of lining will take place. And very common feature is rust and bodies, which will be seen in the connective tissue component. Sorry, it is in the connective tissue, and it can be in the OEPTL also. And the connective tissue wall of this cystic is that thin fibrous connective tissue wall, which is derived from the dental follicle, and which will be less densely and more highly cellular, and fibroblast widely separated by the stroma and ground substance, which are rich in glycosamine mucopolysaccharides, and strands of odontogenic epithelial lining, odontogenic islands may be present. Strands of odontogenic epithelial islands may be present. And then based on the IHC, Cytokeratin 18 is expressed in dentigerous cyst and it is a sign of oncofetal transformation of these lesions. And K67, it shows less compared to the proliferating activity of the cyst is very less when compared to the OKC. And embryonic EMA and CEA, these are found in the most epithelial cells, and epidermal growth factor, which is less compared to the OKC or KCOT. And the differential diagnosis is the dental follicle, because it is very difficult to differentiate whether it is a dental follicle or the inflamed dental follicle or it's a dentigerous cyst. And pericorneal radiolucency, if it is more than 3 mm to 4 mm, if it is more than 3 mm to 4 mm, that means 5 mm, it is like it's called as dentigerous cyst. Other one is epithelial OKC, which is in which epithelium is uniform and corrugated paracarcinate stratified squamous epithelium with palisading and nuclear hyperchromatic nuclei will be present in the basal cells. Ameloblastoma, which is unicystic, which is where the columnar basal cells in reverse polarization, nuclear hyperchromatism, superficial epithelial layer resembling a stellate reticulum and subepithelial hyalinization will take place. So coming to back to the management, in children, the conservative surgical treatment will be required. If it is a large dentigerous cyst, then marsupiation followed by the other surgical procedure. First, if the tooth erupts, அப்படின்னா enucleation will be there. Tooth erupted அப்படின்னா enucleation. Orthotraction waiting for 100 days அப்படிங்கும்போது if within extraction பண்ணிதான் ஆகணும். Then finally, if it is tooth is erupts completely, it is called enucleation. What is the complications from the dentigerous cyst is ameloblastoma, squamous cell carcinoma because of the metaplastic condition, and intraosseous mucoepidermal carcinoma where they have the mucus cells in the lining epithelium. So carcinomas arising from the odontogenic cyst is like rare, but represents 1 to 2% of all the oral carcinomas, and mostly seen when the residual periapical cyst or dentigerous cyst, and also few cases arises from the orthokeratinosis to odontogenic cyst, and symptoms will be pain and swelling. Some cases are asymptomatic. Radiographically, it will have a ragged and irregular borders. So pathological features will be when it is related to SAC. I mean, if it is a complicated, if it is or the tumor arising from dentigerous, the dysplastic changes will be found in the epithelium, cystic epithelium. They'll be having a lot of proliferation thick in the. See, this is very thickened. The epithelial lining is, there will be epithelial proliferation and also the hyperchromatic nuclei and loss of adhesion or cohesion, and the hyperchromatic nuclei, alteration nuclear cytoplasmic ratio. Some of the few dysplastic changes will be observed in the epithelial lining, and retiridges also will develop. So this will mostly differentiate from the normal dentigerous cyst, and mostly well differentiated differential squamous cell carcinoma occurs, and the survival rate is 5-year survival rate is 50%. Intraosseous MEC, if it is developed, it is also one of the complication where 2 to 4% of mucoepidermal carcinoma arises in jaw, and 42% of this intraosseous mucoepidermal carcinoma arises from dentigerous cyst. See, we can see the mucus cells, and this is epidermoid cells. So coming back to this dentigerous cyst as a potential ameloblastoma, there is still confusion because ameloblastoma can be incorrectly interpreted as dentigerous cyst, seeing the site of the lesion and radiograph. Subsequently, the lesion will be diagnosed as ameloblastoma. During the initial biopsy, a thin layer of epithelium can be obtained. Then provisional diagnosis dentigerous cyst, and pathologist will follow this, and later during excisional biopsy, it will be diagnosed as a ameloblastoma. Erroneous conclusion that ameloblastoma developed from the dentigerous cyst. So, coming back to this, then some islets of epithelium are sometimes found in the cyst wall, some distance from the epithelial lining, and these have been misinterpreted as ameloblastoma. And unicystic ameloblastoma also very common. So, erroneous conclusion that ameloblastoma developed from the dentigerous cyst. The syndromes associated with dentigerous cyst is cleidocranial dysplasia, basal cell nevus syndrome, and Lower syndrome, which is called oculocerebrorenal syndrome. So coming back to the next important cyst, which is called calcifying odontogenic cyst. So it is also called calcifying epithelial odontogenic cyst or Gorlin cyst, which is described by Gorlin in 1962. An histological resemblance is to cutaneous calcifying epithelioma of the Malhere. And Lee and Yu divided it into a cyst, benign and malignant tumors. They divided in 2003. They divided it as first as a cyst, then it is benign and malignant tumor. So classification given by Prætorius et al. In 2006, he told it is group 1 is a simple cyst. Group 2 is a calcifying cystic odontogenic tumor. This is associated with odontogenic hematomas and benign neoplasms. And it's also associated with odontome, aortis, ameloblastoma, ameloblastic fibroma, ameloblastic fibroodontoma, and odontofibromyxoma. In case of group 3, it's called dentinoid ghost cell tumor, solid benign odontogenic neoplasm with the dentinoid formation. And group 4, it's called ghost cell odontogenic carcinoma with a malignant odontogenic neoplasm with features similar to that of ghost cell tumor. So first it is called simple cyst. Second, it is called calcifying cystic odontogenic tumor. Third, it is called dentinoid ghost cell tumor. Fourth is called ghost cell odontogenic carcinoma. So it is from cyst to tumor. Coming to the clinical features, it's very rarely encountered, and peripheral and central varieties have been occur frequently, and they have a same frequency, or they can occur in equally. And age, it will be peak in the second and third decades, and it is with the most common with the odontome. Most commonly, younger people are affected. Equal gender predilection, race will be there is no predilection for the race, and equal frequency in maxilla and mandible, most commonly in the anterior part of the jaw. In mandible, they cross the midline, but this is very less in maxilla. So, equal frequency will be found in the maxilla and mandible, and most commonly in the anterior part of the jaw. And in mandible, they cross the midline, and but this is very less in maxilla. Site of peripheral lesions, maxillary mandibular gingiva and allomucosa also develop, which is a peripheral variant of CUOC. So this is a clinical variation which is showing the percentage where it is more common. It's more common in the anterior area, followed by anterior mandibular, and next it is like middle third. That is premolar canine and premolar areas, and in the mandibular next is molar, and in the mandibular area this is in maxillary area, and 2% is the last, which is a maxillary tubulosity region. And the clinical presentation, they shows hard bony expansion. See, there is a hard bony expansion, and which is very rare. And lingual expansion will be more, which is sometimes seen, and sometimes perforate a cortical plate and extend to soft tissues. A few cases development of teeth will be there. Some cases they appear as a asymptomatic. And peripheral lesions, they show pink to red in elevated mass. They appear as a pink to red elevated mass measuring about 4 centimeter in diameter, and occasional recurrence will take place. Radiographic features with the central lesion which is showing unilocular radiolucency, well circumscribed border with variable amount of radio opaque material, and the displacement of root and the root resorption will take place. See, there is a displacement of the root and root resorption, and also the unilocular radiolucency with a well circumscribed and with a variable amount of radio opacity material. So in case of peripheral lesion, it will having a peripheral variant, means mostly involving the soft tissue. So the localized superficial bone erosion will be there, and saucer-shaped radiolucency will be there. So this is the histopathological feature which is showing a ghost cell with epithelial lining and also connective tissue component. In 1922, it was given by WHO. So coming back to that, if it is COC with that is calcifying odontogenic cyst with amelobllastic fibroma, the component of amelobllastic fibroodontoma, and the same lesion with the dentinoid. They have a dentinoid material. Connective tissue wall, it will have satellite cyst and ghost cells. The connective tissue evoke a foreign body reaction and formation of multinucleated giant cells. Islands of odontogenic epithelium will be there, and the atubular dentine will be found. Ghost cells also present, which is very common in COC, that is calcifying odontogenic tumor, odontogenic cyst, ameloblastoma, odontoma, ameloblastic fibroodontoma, carcinopharyngioma, calcifying epithelium of Malherbe. So whether this is cyst or tumor, because in the 2005 and 2000 in 1992 they considered to be the cyst finally, and then later on it's converted into tumor. Now in 2017 again it is returned back to the cyst form. So remnants of odontogenic epithelium, so there will be a cyst. So dentinoid at benign neoplasm from the cyst wall, which is the initial lesion is the cyst. So malignant transformation, where there will be malignant transformation, it will be the ghost cell odontogenic carcinoma. Ghost cell odontogenic carcinomas can arise from the other odontogenic tumors. So ultrastructurally, the ghost cells of calcifying odontogenic cyst will show keratinized cells from the from oral epithelium. The ghost cells, the site of the ghost cell contains tonofilament separated by the empty spaces, and cytoplasm contains needle-like sutures of hydroxyapatite between the tonofilaments. So evenly distributed fine tonofilaments will be found. Ultrastructure of the ghost cells, which will be diameter of the haphazardly arranged tubules of tonofilament, which is of 60 to 20 micronanometer, and adjacent ghost cells are attached by desmosomes and contains vesicles of 90 to 450 nanometer, which is matrix vesicles. Needle-like structures will be hydroxyapatite. So this is a special stain which is used to identify the ghost cells, which will appear red staining and demonstrate dentinoid, and the yellow staining of ghost cells. So these are red staining is the dentinoid material, and yellow it is the ghost cells. Ghost cells is the same histological reactions as a keratin, giving a yellow fluorescence with the rhodamine. Ghost cells, according to the HIHC, express just enamel-related proteins like amelogenins and enamelysin, expresses human hair proteins. And in case of cytokeratin 9, only slight predilection, so a slight difference in the BCL2 and K67 expression among various histological types. So coming back to the treatment, enucleation is the one of the treatment, and it's with the complex odontome, conservative enamel, wide excision associated with other odontogenic tumors. And if COC is associated with the ameloblastoma, it should be treated like ameloblastoma. And the recurrence is very rare, and cosmetic transformation has been recorded. So coming back to the gingival cyst of infants, this is called alveolar cyst of infants, also small superficial white cream colored keratin filled cyst on the alar ridges of the newborn or very young infants are affected. Common lesions reported to be occur in the half of the all newborns. Gingival cyst of newborn, which will be more common in the very less in the 3 months of age, and most of them erupts through the surface epithelium and exfoliate. Others originate from the remnants of dental lamina. So it's equal gender is affected, and mostly maxillary alveolus is involved, and size will be 2 to 3 mm. And two inclusion bodies which will be affected, or inclusion cysts which will be present in the cyst infants, which is called Epstein pearls or the bone nodules. And Epstein pearls means even seen at the mid palatine raphe due to the epithelial inclusion at the line of fusion of palatine shelves and nasal processes. And in case of bone nodules, or at the junction of the hard and soft tissue palate, arises from the glandular tissue. So pathogenesis of gingival cyst too, we know that it arises from the remnants of dental lamina, and in the late Bell stage, distinguishing of dental lamina occurs. So it is the answer is Bell stage. In which stage the remnants of dental lamina will take place? It is called Bell stage. And next, the islands of dental lamina can be seen between the two germ and the oral epithelium. And finally, the some cyst extends to surface and ruptures for few months after the birth. Some cysts degenerate, the content will be digested. So coming back to the histopathology, we all know that epithelial lining is devoid of reti ridges. They lacks reti ridges, and the lumen is with the full of desquamate epithelium, which is called keratin flakes, or and a few inflammatory cells, and connective capsule, which shows a few inflammatory cells. This lining of epithelium, which is called stratified squamous para keratinized epithelium, and basal cells will show a basal cell appearance. So no treatment is required for gingival cyst of adults. And next, gingival cyst of adults, which is called uncommon lesion and considered as a soft tissue counterpart of lateral periodontal cyst. And why it is gingival cyst and lateral periodontal cyst are considered to be the same? Because they have same site of predilection, same clinical and histopathological features, and the origin is cell of origin is 1965. Bhaskar et al. He grouped these lesions into gingival cyst and considered as a two. Both lesions arises from the odontogenic epithelium. 1975, Shear and Pinbock considered this as a clinical lesion. Frequently, it's a very uncommon lesion, and the age will be 5 to 6 decades, and site will be premolar region of mandible on facial gingiva and alum mucosa. The size will be usually less than 0.5 centimeter. Clinical features: it's a slowly growing round or oval painless swelling and attached to the gingiva and facial aspect of interdental papilla, and smooth surface appearance will be there. Normal color of the gingiva will be appear with sometimes bluish tinge will be found, and soft and fluctuant in consistency and associated with vital teeth. Radiographic features: it will show a site, it is a soft tissue lesion, does not manifest, and in dental radiograph, superficial bony erosions are called. And a possible what are the possible cell of origin? First, the odontogenic epithelial remnants, most favorable theory, and the traumatically implanted surface epithelium, and cystic degeneration of deep projection of the surface epithelium. These are the very pathogenesis which is related to the cyst. So coming back to the classifications or any important two factors, lateral periodontal cyst formed from the reduced enamel epithelium by the dilatation of the follicle before eruption of the teeth, and gingival cyst of the adult is derived from the reduced enamel epithelium after eruption of the teeth. So if it is a lateral periodontal cyst, that will be formed from the reduced enamel epithelium by dilatation of the follicle before eruption of the teeth, and the gingival cyst of adult is derived from reduced enamel epithelium after eruption of the teeth. So coming back to the pathogenesis again, it's a gingival cyst of adult can develop from the junctional epithelium, and it is derived from the reduced enamel epithelium. So in case of unaggressive nature of the cyst, it is due to the origin from the post-functional free, and remaining theories of origin may or also may be theoretical. And in case of multicystic variant, it is occasionally found in the gingival cyst, most frequently in the lateral periodontal cyst, and multicystic variant arises from the epithelial plaques pinched off from the mother cyst. Origin of the cyst, which from the dental lamina, and suggested that the polycystic forms may develop from the multiple epithelial cell rest of dental lamina. So epithermoid variety of gingival cyst and derived from the cell remnants of dental lamina that survived to adult life. So coming back to the histopathological features, first will be the cystic lining, cystic lumen, cystic lining, and gingival epithelium. Cystic lining is very thicker with stratified squamous epithelium. There is no reticulus found. And the localized area of node, thickened epithelium, clear cells are found. Epithelial cells easily peels off, leaving epithelial discontinuities, and the connective tissue is relatively uninflamed. Differential diagnosis will be periodontal abscess and also the peripheral variant of OKC. Periodontal abscess will be having which will be in the because of the infection in the periapical region, there will be abscess development, which can periodontal abscess or any of the periapical abscesses, and it is thicker. Uniform layer of epithelium, palisaded basal layer, corrugated wavy layers of parakeratin, and desquamated epithelial keratin in the lumen of the cystic cavity. So this is to be continued. Today's session is over, and the chapter of odontogenic cyst will be continued in the next session of next class. So have a nice day. Thank you.